Good evening, everyone. This is Meldita and I'm back. So this is dialysis. Is it temporary or permanent? Before going further, I will show you this dialysis filter here. Let's make a cross section. This one here. So this filter is made up of many or countless hollow fibers. And there's blood inside each of these fiber, circular, and surrounded by semi-permeable membrane. And outside, you see this yellow is dialysate. Okay. Going back to the principles of dialysis here. Diffusion. When we speak of diffusion, we talk about concentration gradient. So inside the blood, there's an increased solute concentration. There's a semi-permeable membrane. That's where the solutes pass. And they go down to the dialysate with lower solute concentration. So the driving force here is the solute gradient or concentration gradient. Next is the ultrafiltration. When we speak of ultrafiltration, we speak of fluid. So here we have a pressure set up artificially by this machine. So you call that the transmembrane pressure or TMP. Okay, so high fluids in blood passes the semi-permeable membrane with pressure gradient down to dialysate. Last principle, convection. In the convection, it utilizes a very leaky membrane. In here, our aim is to remove large amount of fluids and solutes in the blood. They pass this very leaky membrane down to the dialysate. Well, there are three kinds of dialysis that I'm gonna be talking about. First, we have the hemodialysis, peritoneal dialysis, and the CRRT. Hemodialysis, the access site in hemodialysis here is the AV fistula. Sometimes they use a graft, but commonly, we use the AV fistula. So in here, there is an artery that is in red, and there's the blue one that is the vein. So the doctor from the interventional radiology, they actually anastomose this. These doctors will anastomose these vessels. So they suture them to make a fistula. And they wait for 2 to 3 months before this matures. So what they're actually waiting is to dilate this vein. So that's the AV fistula. So it takes 2 to 3 months to happen. And if they cannot wait for this and the patient is already in failure, very bad, they're gonna do a permacath insertion first. So here, assuming the patient was able to wait, then they can use this one. And they can start the hemodialysis here and they will use this fistula. So the red tubing is the pulling out catheter. It comes from the artery, and the blue one is then it goes to the filter, and the blue one is the clean blood that goes back to the patient. Okay? And in here, the indication for this is for end-stage renal disease. Yes, it is permanent, but it could be temporary while the patient is waiting for kidney transplant. So the principles involved here is diffusion and ultrafiltration. And we have complications, however, because we draw fluid. So we have low blood pressure that could possibly happen. Arrhythmia could happen. And because of some, electrolyte shift, infection, and that's just temporary. So the bad part with this AV fistula is hyperplasia. So there will be restenosis, and the patient might be indicated for ballooning or angioplasty of this spot to enlarge it. Okay, clots, they're easy to manage. Okay, permacath, there are some people that cannot tolerate, AV fistula, so permacath. So this is a tubing inserted or tunneled underneath the skin. So the tip of this catheter will actually go to the SVC, to the superior vena cava. And the tail part, this part of the catheter is actually put under the skin. They call it the tunneled or buried. The tail part here exits out, and we see these two arms, the red and the blue. So the red arm will get that is the pulling catheter. pulling catheter that takes the blood out, goes to the filter or dialyzer. Clean blood will go back to the blue one, back to the patient. Okay, and the main problem is infection again. So all caregivers should be good in doing good hand washing technique, aseptic technique. And for clots, they usually apply TPA. They kind of dissolve the clot. Okay. Next is the peritoneal dialysis. In here, the semi-permeable membrane is actually the parietal peritoneum that is surrounding these organs inside. There's a visceral peritoneum that is surrounding each organ, but the parietal is what we're concerned. Now, this parietal peritoneum is actually rich with blood vessels, and they are the one to serve as the semi-permeable membrane. So what they do with access is the doctor, the nephrologist, they make a hole or incision on the abdomen, and down they put a catheter into the peritoneal cavity. So then they will use this one for dialysis. So they have exchanges, fluids, that is ordered just like the hemodialysis. The solutions used are ordered. This one are ordered. Exchanges, percentage, volume, frequency, all these things. That will be ordered by the nephrologist. So they usually do it a daytime, 4 or 5 times a day. And the principles involved is diffusion. So the semi-permeable membrane. So toxins or anything unnecessary, not good elements from outside the peritoneum will be sucked in, and it goes to the dialysate. And for how we're gonna apply the ultrafiltration in here, by using the process called osmosis. So they increase the percentage of the glucose at night, and that will suck fluid out. You notice that one that at night it's always a high percentage of glucose. That is to draw fluid from the body out to the peritoneum and out to the dialysate. So again, the problem here is they use this for end stage as well. And diffusion and ultrafiltration using osmosis are the principles utilized. The problem is infection. And we have also external and internally. When they are infected inside, because glucose invites actually infection, they can have purulent, discharges or, abdominal pain. Those things will be addressed. They will put antibiotic. Sometimes they go fluid overload, which is bad. Or maybe there's a scarring of the peritoneum, and that will require the patient to advance to hemodialysis. Sometimes, so that is the daytime. That is the daytime dialysis, 4 or 5 exchanges per day. And we have also the nighttime. They will train this patient to use a cycler, 7 to 8 hours. They hook themselves at night and they feel good in the morning. So this is a cycler, and they will be trained before, they go home and do it themselves. But there's always an on-call to be called in case of emergency. The other dialysis here, the CRRT, this is the continuous renal replacement therapy. This is actually used in the ICU, and this is actually indicated for acute kidney injury. Very sick patients, they are actually hemodynamically unstable, and they require, and this kind of dialysis is actually a slow, continuous dialysis for 24 hours. And they also use the principles of ultrafiltration, convection. There's a large amount of fluid out, and there's a mass transfer of solute out because it's a leaky semi-permeable membrane. So again, problem is infection, class, low pressure, arrhythmia, and things like that. So what are the accesses of this CRRT? They go to the femoral vein. They go to the femoral vein. Sometimes they will